There's a truck going by, and he has to tell people he lives here. Yeah, hold on. I'm going to mute and tell him to be quiet.
The dog is some protection, so that's nice.
Yeah, I have 3 of them. This is the only one that feels the need to talk about himself constantly. Okay, so we are live, and we've got people coming on. I'm going to go ahead and make sure that Diane is here to let us know that we sound good everywhere, or if anybody could hop out into the Facebook group and check me out there and make sure that we have volume, and then also pop into the chat. Anyone, first one to say, yes, we hear you, sounds good. Thank you, Diane. You're so good. I didn't even know you were on here, and you've already taken care of everything. Wonderful. All right, you guys, here we are again with Dr. Alan Hopkins. We are going to do a little bit of a different introduction here because you guys are really getting to know him. And for those of you who don't know him, and a lot of new people in the Clarity group in the last 2 weeks who don't know me, I am the founder of the Institute for Functional Health Coaching. I am the creator of the Health Coach Clarity groups we are streaming live into right now, and the founder of the Health Coach Mentorship and Mastery group. And my passion is mentoring and educating health coaches and kind of moving all the crap out of the way so you guys can get to the business of running your business. So Dr. Alan, if you'll tell us a little bit about yourself, we'll go ahead and jump into the diabetes presentation after that.
Oh yeah, sure. So hello, welcome everybody. I'm actually coming to you live from Sedona, Arizona. So at the very end of this, I'm going to take you guys outside and show you pictures from the balcony, just so you can appreciate. That. Oh, you can appreciate it. It's pretty awesome.
Cool.
But so I'm an ER doctor. I've been an ER doctor for about 20 years. Did a fellowship with A4M about 8 years ago. Became a consultant for companies, and one of them just happened to be a company called Prediabetes Centers. And I became their medical director and supervised multiple physicians across the nation as we looked at intervening in prediabetes and reversing prediabetes. So this is a subject that I'm quite familiar with, and I'm excited to tell you at least what I know about it and how I think health coaches can actively intervene and actually help people in a dramatic way and prevent diabetes.
Awesome. I'm so excited to hear about this because, you know, I think that there's a lot of misunderstandings around this topic. Oh my gosh, right? Is Amy videoing you? Is that you making faces? I saw her sweeping around behind. Everybody say hi to Amy, the beauty behind the brains and the brains herself. My gosh, it's such a pleasure to get to know both of you. So let's go ahead and can you, before you start your presentation, all I would love for you to do is to briefly give us a little definition of type 1 diabetes and type 2. Just kind of pull those two pieces apart because people get really confused about which one is which and what they mean. So can you start there before you launch into your presentation? That would be fantastic.
Yeah, absolutely. I'm glad you mentioned that because when we talk about this subject, we're focusing on type 2 diabetes, which is the predominant problem here in the United States. We have a significant number of people who have type 2 diabetes, relative smaller number of people with type 1. So what is the difference between type 1 and type 2? Type 1 is like every other autoimmune disease that we see. So when you think about autoimmune disease, we as research scientists and doctors basically said, well, we see that the thyroid's being attacked. Okay, we call that autoimmune disease Hashimoto's. Mm-hmm. After that Japanese doctor in 1912 who discovered the phenomenon. Then we see the body attack multiple organs, the skin, the kidneys, and so on, and we call that lupus, for example. Then we see the body start to attack the bowel in certain areas of the bowel. So if it attacks the distal bowel, we call that ulcerative colitis. If it attacks multiple patchy areas of the bowel, we call that Crohn's. So if it attacks the pancreas, and that's what it's attacking, we call that type 1 diabetes or autoimmune diabetes. So it's an autoimmune phenomenon. That's what type 1 is. And we predominantly see it early on in life, and it's mainly kids. And I've seen it many times in the ER, and it's a devastating diagnosis, particularly for the family, because you're telling their child that they're going to have to be on insulin. Mm-hmm. If you don't treat type 1 diabetes, then these kids will die right away within a few weeks because you absolutely have to have insulin to live. And as you can imagine, a child comes in and they're throwing up and they're complaining of abdominal pain and they look quite dehydrated. Well, how do we get to that diagnosis? Well, we do blood work on them, and we'll see their glucose levels be 500 or 600. And then they oftentimes are in something called diabetic ketoacidosis, and their blood sugars are extremely, extremely high, and they're almost near death when we see them. So many years ago, just to put this in perspective, in 1902, there were two doctors that were tired of seeing people die from autoimmune diabetes. And so they thought there must be something in the gut that helps preserve the pancreas and keep it alive. So they began to take people that died and they would take the gut and they would feed it to these children in hopes of having those children, survive and live. And of course, it didn't work, and these children died anyway. And these guys were made up, they're made fun of basically and chastised by the rest of the medical community. But the truth is, they were actually onto something. And it wasn't until the year 2008 we actually discovered that there was something called glucagon-like peptide that was produced in the small intestine that actually would encourage the pancreas to produce more insulin. And so, unfortunately, it doesn't work for type 1 diabetes, but it certainly helps out dramatically for type 2 diabetes. When you have type 1 diabetes, the diagnosis is made when you can't make any more insulin. And we just see this in young kids predominantly as an autoimmune phenomenon. Now, 7% of all adults who are thought to have type 2 diabetes actually have latent autoimmune diabetes of adulthood. That's called LADA, L-A-D-A. And this is commonly missed because we think these people, have type 2, and then we put them on maybe oral medications and fairly restrictive diets, and they progress rapidly. And then ultimately we say, wow, you're not producing any more insulin. You're very likely actually a type 1. So again, type 1 occurs predominantly in children. That's where the majority of 90-plus cases occur in children, usually between the ages of 2 to 10 is where they most commonly present. But the rest of them, very small minority, can actually be in adults. So people always ask me, how can you tell the difference if an adult has type 2 or type 1? One of the big tip-offs is you have an adult who's at normal BMI. So again, one of the biggest risk factors for developing type 2 is, you're overweight, you're eating too many carbs, and you're just overwhelm your pancreas's ability to keep pumping out insulin. And so your body just gets tired. So autoimmune disease, type 1, you go in there, your body attacks the cells called the beta cells, and it totally destroys them, and they just can't make insulin anymore. And for most people, it's a fairly rapid decline, over a period of weeks to months. And again, those people are at high risk of dying without intervention. And, back decades ago, those people would die almost universally. And we still have problems overseas in some impoverished countries that have limited access to healthcare. I remember I worked in a clinic in Nepal. We saw several cases of diabetic ketoacidosis due to type 1 diabetes, and mainly in children undiagnosed. And so many of those children don't do well overseas, but here in the United States, we will catch them almost all the time because we tend to do the blood work and IV fluids and that kind of thing. But again, a kid can come in with vomiting and abdominal pain and have a virus, that's 99.9% of the time what it is. And then it could be an appendicitis and so many other things. So we tend to do a full workup on those kids. And we don't tend to miss that very often because the kids are quite ill. And they're breathing fast and all these other signs of having a metabolic disturbance.
How does it get to that point? How do people's children get to that point where they come in and it's that, that close to death or that close to being serious? Is there not a lead up like, oh, I don't feel so hot, and then some hours go by, mom, because if my kid gets a stomach ache, it's on for him. He's like, oh, I have a stomach ache, and it goes on for hours. I'm like, okay, did you get into some gluten or something? Is that what the problem is? You know what I mean? I hear about it right away. So how does that happen that someone, has a child that gets that violently ill and they almost die by the time they get to the ER?
Yeah. Well, again, what happens with the beta cell is it still produces insulin until the point where it just can't produce it anymore. And when that switch is turned off, you have the sudden onset of very high blood sugars. And we see it happen quite rapidly in children. In adults with LADA, L-A-D-A, with the latent adult autoimmune disease, they tend to have a more slow progressive course, but children tend to have a fairly rapid course. And the truth is, it's because children are able to tolerate higher levels of blood glucose well before an adult would. So kids are unbelievable. I mean, they're like plastic. And we always, talk about it as ER doctors. If you make a mistake, it's really actually hard to kill a kid because you can make a mistake and the kids are resilient and they can just, if you give them the wrong medicine or you don't give them quite enough of this or that, they're very resilient. So they're plastic and they can survive so many things that adults can't.
Mm-hmm.
And so when they actually get completely turned off on the insulin, they'll hang in there and they'll hang in there, and then all of a sudden, boom, they just crump. And that's actually how children, when in resuscitations, it's the exact same way for almost every disease. They hang in there so much longer than everybody else, and so we always kind of talk about how children are just amazing and their ability to fight through things.
Yeah.
And so unfortunately, when they have autoimmune disease, it almost always is one of those crumping situations. And that's why we tend not to miss it here. And that's why they tend to die in some of these impoverished countries fairly quickly, because without immediate access to intervention, particularly insulin and IV fluids, they just die.
Terrible. Okay.
Yeah.
All
So
right.
that's the difference. And maybe that sticks in people's minds. Type 1 is sort of more of an emergency because you have to have insulin. Type 2 is one of these things where if we intervene earlier in the course of the disease, we can reverse it. And I'm going to show you how just 1 year of reversing it can buy that person about 11 years of being without it.
Okay.
And that's type 2 diabetes.
Awesome. Go ahead and start your presentation. And as a reminder, you guys, if you have any questions at all or anything that you want to know, put it in the Q&A. Please don't put it in the chat. Putting it in the Q&A helps me to focus and keep things efficiently running. And we are going to be good stewards of Dr. Allen's time today. And we are, if the questions keep coming in like crazy, like they did yesterday with the other Dr. Allen Christensen, we're going to have to cut off at some point. So, try to see if the question is already posted before you post it, and just kind of hang in there through the presentation because he may answer it before you even ask your question. Okay. All right. Go for it.
I love Dr. Allen Christensen. That's awesome. I saw that you
gosh.
had him on yesterday. That guy is so smart, and he's an awesome person. He's an awesome human being.
He is. And just hilarious in all. I mean, just even listening to him laugh, he's got a contagious giggle. I mean, it just takes over.
Yeah. He knows how to have a good time. That's for sure.
Sure.
Are you able to see my screen?
No, not yet.
Oh, okay. Do I need to do anything?
Yeah, on the bottom there, your little green folder on the Zoom, it'll say share. So if you click, make sure everything obviously is personal.
Oh, okay, right. I forgot.
Because we're about to see your
I
life.
think I would know this by now.
That's okay.
Okay, so let me just try this and see if this works.
Yep, there you go. Perfect.
Okay, so let me just play this from the start. Okay, all right. So what we're going to talk about today basically is insulin resistance, because I want you to understand what that is. Prediabetes, okay, because there are definitions for prediabetes, and then diabetes, of course. We're just going to sort of touch on these three topics. So Carmen and I kind of already talked about this. Let me get to the next slide. So we already talked about sort of my background. I'm just going to mention right now I'm working for the Dell Medical School, and we do a lot of teaching. And so this is kind of fun for me. A lot of these slides I just sort of modify a little bit because a lot of them have been pre-made over time. If you should have any questions, I'm always open to answering questions. I actually like to answer questions because oftentimes I'll get asked questions I don't know. So that makes me actually go and learn more. So that's good. So the idea here is we want to understand the breadth of the problem, what sort of a situation we find ourselves in as a country and really in the world. I want you to understand the basic pathophysiology, so how it happens, and then we're going to look at the actual definitions so that you'll understand when you see it. And these definitions are based on blood work. And then finally, how you can help, because this is the most important thing is, you play a tremendous role in actually intervention and reversal. And I'm going to show you how many people are doing this across the nation. So you're at the right place. So the problem, so we're kind of like the Titanic sailing along right now, okay? And on the surface is type 2 diabetes. And we're talking, for the purposes of this lecture, we're talking about type 2. So on the surface, there's all these millions of people with diabetes. And what we don't see underneath the water is the amazing amount of people who actually have prediabetes, and most of them do not know it. Most of them aren't getting checked, and they have no idea that they have prediabetes. And so at the end of the day, I want you guys to care about prediabetes. I remember when I first got into this, it's kind of funny because somebody came up to me and say, well, okay, I don't understand. You guys call it prediabetes. Isn't that like anything else? I mean, like, you could have pre-anxiety, or you could have your pre-athletic, or you know what I mean? So they're kind of saying it wasn't, they're trying to say it wasn't really much to worry about. Well, the truth is prediabetes actually increases your risk for multiple certain types of cancers. And believe it or not, it actually increases your risk for having a stroke and a heart attack. Because in prediabetes, we begin to remodel the way we make our bad cholesterol. And we tend to make more small, dense cholesterol that's more disease causing. And also along with prediabetes, because it's a metabolic disturbance, we tend to see elevations of high sensitivity CRP indicating inflammation. And if we measure it over time, we'll see that metabolic disturbance leads to chronic inflammation. So again, the triad of early stroke and heart attack is based around small, dense cholesterol, chronic inflammation, and blood sugar problems. Cancer happens to like sugar. And so in any situation where you have higher sugar levels, you can be at a much higher risk of developing cancer. So these are the things that we worry about when we talk about prediabetes. And we've done a terrible job. I'm speaking conventional medicine and doctors. We've done a horrible job at prevention of diabetes and particularly screening for prediabetes. And I say that because in 2011, when the CDC put out numbers, we had 79 million prediabetics and 26 million diabetics. 3 years later, where these stats are from, it had climbed to 29 million and 86 million people. So what I'm saying is that, like, despite our best intentions and our focus on this, we're just not doing the job, and we're failing to intervene in situations where it should be really easy to intervene. It's an easy test anyway. People should know. All right. So if we look at the natural history of type 2 diabetes, now this slide here was a presentation for the physicians, and it does come from the Journal of Endocrinology. And what I wanted to understand here is if you look at the onset, so at the very bottom on the x-axis, 0 is the onset. So 0 is the time in which we actually have enough failure of the beta cells that our blood sugars begin to progressively rise. By the time you get diagnosed with diabetes, there's been a lot going on for many, many years. Mm. So if you can look at this x-axis, we start at minus 15 years, and then we go to sort of minus 5 years and then 0. So you can see this tends to be a slow, progressive disease. And one of the very first findings we see in somebody is actually insulin resistance. So you can see that curve. It kind of looks sort of orange yellow to me, but that curve on insulin resistance starts climbing fairly dramatically between 5 to 10 years before the onset of actual diabetes and high blood sugar. So one of the first findings that we'll see before we see the glucose even going up is insulin going up. So if we measure fasting insulin level in people, that will be the first sign that they're on the road to diabetes. So if you really want to know, okay, what is a good screening test? It's looking at fasting insulin levels along with fasting glucose levels and finally your A1C, which we'll talk about in a minute. There's all kinds of things. Is that
always the case? Is it always the case that insulin resistance happens prior to?
Yeah, so let me know. It said my internet connection was unstable, so let me know if anything goes wrong on your end there. Okay. I guess you won't be able to hear me, but so the idea is that most people actually never check fasting insulin. Mm-hmm. Okay, I mean, I'm talking about conventional doctors. If you were to ask, say, 100 of them, I would say 99% of them don't really know much about it, and they don't check it.
Yeah.
So again, what I'm trying to teach you guys, and by the way, I would say probably 90% of doctors don't really do too much for prediabetes. They say, well, watch your weight and exercise, and it's a 5-minute visit in the office. And, you leave the visit confused because you're not sure what type of exercise, and you're not sure, okay, eat better. What does that mean? Does that mean eat less carbs or whatever? So I want to talk about specific interventions at the end that you can actually tell people. But the idea is that we're never checking for fasting insulin. We just don't check for it enough. And if we did check for it, we would find it. It's kind of like lipoprotein A. You and I have talked about lipoprotein A before. 20% of the population has it. It's a huge risk factor for developing a heart attack, and nobody's checking for it. This is like another biomarker we consider to be an advanced biomarker that people typically just don't check for. So they don't know much about it, and they kind of poo-poo the idea. But if you actually look at the research, you can see that insulin is the first thing that starts rising. By the time you are a diabetic, you are maximally insulin resistant, meaning that your insulin just doesn't work. So insulin resistance is all about how well your insulin actually works. All right, so the next thing I want you to look at is a fasting glucose. So you see that a fasting glucose is a very slow thing prior to diabetes to rise. So it eventually rises to a point of 126, and that's when we call you diabetic. And by that time, it tends, after that, you can see it just starts rising faster and faster. So, so a lot of things lead to this, and probably the most important one is genetics. If your mother has diabetes, you're very high risk. If your mother and father both have diabetes, you're at super high risk. If you're a female, you're at higher risk. If you're Hispanic, you're at higher risk. In fact, that's the ethnicity that has the highest risk, is if you're Hispanic. If you're overweight, of course, that's a big risk factor. And then other things like, our diet and all that's come into play. And certainly we're seeing that now, really since the 1970s, when we replaced all the fat with sugar, we're seeing enormous amounts of people falling into diabetes that had no genetic risk factors. In fact, I would say probably about 80% of my patients had no risk factors, no genetic risk factors. They just, ate terrible, didn't exercise, and they just fell into this problem. All right. So why do we care about this? Well, we care about it because at the end of the day, the number one cause of blindness here in the United States and the number one cause of kidney failure is due to uncontrolled diabetes. These are huge humanity costs. If you can imagine, when you do have kidney failure, your life is turned completely upside down because you're dependent on going in 3 times a week for 6 hours to get dialysis. And so your life becomes about going back and forth to dialysis. If you don't have dialysis, you will die. Blindness, of course, it's the number one cause of blindness, and of course, very difficult to treat diabetic retinopathy. So it's just where your retina just basically starts to die off due to the lack of adequate blood flow back there. And of course, it is still the number one cause of amputations. So diabetics tend to get infections quite easily. They have to inspect their feet because they don't feel anything. They get nerve damage, and that nerve damage allows them to walk on hot coals and not feel anything, but develop a blister and then get an infection that causes them ultimately to get an amputation. And then the CHD is just, cardiovascular disease. So it's just, it's heart disease. And so again, it's a huge risk factor for developing heart disease. So again, it's a progressive thing. As we see high insulin levels, we start to develop the problems with the blood sugar eventually going up and the atherosclerosis. And again, some of these things we talk about, genetic susceptibility, the environmental factors, that's huge right now. Mainly, we're just all eating terrible. We're not exercising. We're not building muscle, which is quite protective. So that's kind of where we're at. And this is why it's important, is because most pre-diabetics will tell you, in fact, 90+% will tell you, Doc, why should I care about this? I feel fine. Yeah, sure, I'm a little bit overweight, but why should I really care about this? And unless you sit down and you talk to them about what the research shows, that you're at increased risk for cancer and heart disease, and you already have ongoing damage. I don't know if you knew this, but prediabetes itself actually causes your beta cells to die faster. The glucotoxicity, even being slightly above 100, starts to kill off the beta cells even faster. So the idea here is to rapidly identify people at risk and reverse them. And if they do already have diabetes, to really talk to them about getting that A1C under as best control as possible, because that will limit the ultimate disability that they could potentially suffer.
Right.
So these are the real facts here. And these come from research studies that have been done. The average diabetic costs about $7,000 to $8,000 per year just in diabetes care. These are medications. These are going to, all the different things, the ophthalmologist, all the specialists they have to deal with. If we do intervene and we reverse diabetes just for 1 year, we can get a benefit for 11 years. So I always tell people, at least my patients, I'll say, look, if we do this really good for a year and we teach you how to eat better and we start to build some muscle and we reverse your blood sugars and we get them back to normal, if we can just do this for 1 year and you go completely off track after that, we're still buying you some time. And so the idea here is that it really does make a difference to intervene. There's this huge thing called the Diabetes Prevention Program, and this is where we've learned all this stuff. And it's a prevention program where they followed people over years and years to look at actually what their performance was with intervention.
So can I ask you a question real quick?
Sure, yeah.
If you'll go back to that last slide for just a moment. So when you say aggressive intervention has shown to delay diabetes up to 11 years, after just 1 year of education and prepping someone to make better choices and decisions, does that mean that, are they always going to have to be on high alert for this to happen if they slip off for a little while or something happens where they, fall off the wagon of good eating or whatever you want to call it? Is this something that they need to be, progressively, just going after it at all costs? You want to make sure that 11 years are like, hey, I'm in the clear. I'm going to go back to my normal standard American way of living, right?
Yeah, they actually always have to be on high alert. Particularly those people that have genetic susceptibility to the disease.
Right.
So, and one thing we'll find with some people is if both parents have diabetes, even with significant nutritional intervention, we may not get much help. And so the idea of a health coach is if they see somebody who has prediabetes, whose both parents have diabetes, that person just needs to know this is going to be a real uphill battle. It's a huge uphill battle because these cells are pre-programmed to die already. So yes, they're going to have to really watch for progression. And the genetics things is something that's the most difficult thing to overcome. People that have genetic issues, both a mother and father with diabetes, and this is my case actually in my family, we really have to really pay close attention over time with the numbers to make sure that they're not progressing despite our best intentions. And I can tell you, I don't like to use medications in people, but in diabetes, in prediabetes is actually really interesting because we found out the latest research done in the last decade has shown that if we aggressively intervene with both nutrition, exercise, and medications, we can take the medications away. And we may take them away for years and years and years. But if we don't do that, what tends to happen is once we start them on a medicine, they never come off the medicine. They have another one added after a couple of years, and then a third one added after a couple of years. So in prediabetes, and this freaked people out a little bit, there's some patients I have that are extremely high risk that I put on 3 different medications, and I put them through significant nutrition intervention, and we get significant reversal. And this is exactly what the research is showing, is that the earlier that we treat more aggressively, the better outcome they have. So our old way of doing things was watch and wait, and tell them to lose weight and exercise. The new way is to better risk stratify them and to be super aggressive. And there's not enough people around that are being super aggressive because, there's a lag between what research shows and what actually gets out to the doctors that are actually practicing, medicine. Right. And so I think that it's coming because I think there's an awareness that's starting to come through, but it's slow. It's been very slow in coming.
So you're talking about with your medications, you're talking about things like metformin or things like that, correct? Or
yeah. Metformin. Metformin is one. Metformin is kind of the mildest thing. Metformin is we like metformin because it's very safe. And if people get past the initial GI upset, the diarrhea, the abdominal cramping that occurs in a significant, about 30% of people will have those symptoms. If we can get past that, which is pretty easy because if they just hang in there for a week or two, all those symptoms go away in 99% of people. But metformin itself is a very mild medication. I actually put people, many of them, on GLP-1s, which are what those guys in 1902 that I talked about, what they actually were thinking about doing was they were giving the human gut to the children, but from their study and their initial hypothesis, we actually discovered this hormone that's produced in the human gut that a company was actually able to make this exact same hormone, a synthetic version. So just like we have bioidentical hormone replacement, now we have bioidentical replacement for hormone that really kicks up the function of insulin and makes that insulin work a lot better. So I'll use GLP-1 analogs in people who have prediabetes if their situation looks like they need it. And one of the best tests to do is a glucose tolerance test, because that glucose tolerance test really tells me if their pancreas is actively dying or not. And I can talk more about that. But I think for the purposes of health coaches, the idea here is that we are going to be as aggressive as possible with nutrition and education and exercise programs that really have been shown to work. And part of the education piece is telling people, look, your genetics are going to play a huge important role here. And I'm sorry, but both your parents have diabetes. You're very high risk despite our best intentions. So we're going to have to make sure that a doctor is closely monitoring you to see if you need to be on medications much earlier. Some health coaches that I've interacted with are pretty much no to medicines all the time. I mean, it's like conventional medicine and medication. As an ER doctor, I have a different perspective, only because I've literally brought people back to life with medications. Without those medicines, they would be dead. Right. So medicines really do work in the right situations in the right person. Right. And so I think the education piece has to be, if they have genetic predisposition to diabetes, being okay with saying, look, you should talk to your doctor. There might be medication intervention that could be started early as opposed to wait till you already have it. So as you progress from prediabetes to diabetes, it turns out that 50% of your pancreas dies. It dies in prediabetes. And if we measure the efficiency, you will lose 80% of the efficiency of the pancreas in prediabetes. So the idea here is to intervene very early on in the pre-diabetic process to save your pancreas. So I don't know if that makes sense at all, but that's
it does.
What
So
I
do you
recommend.
test beta cells? Are you going to talk about testing on how to tell if the pancreas is in good health or beyond insulin?
Yeah.
Okay.
Yeah, so I want to talk about the basic testing first, and then I want to talk about some more advanced things that we do for people.
Okay.
So here's the first thing is insulin. Because insulin resistance is the real reason behind a lot of the problems we're seeing with people that don't have a genetic predisposition. Prior to 1980, we really didn't see any cases of type 2 diabetes in people under the age of 20. So our children were not getting type 2 diabetes. They were getting type 1. They were getting the autoimmune disease. But after 1980, we began to see many, many cases of people under the age of 20 developing type 2 diabetes. And why was this? Well, we were all eating horrible, and we replaced all the fat with sugar. We began to pound our pancreases day after day after day with all the sugar. And in order to get sugar to go into the cells, we need this hormone called insulin. Insulin is made by the pancreas. And what happens is because we're young and still hardy, and because we don't have genetic problems, we can shoot out that insulin super high. So we can have insulin levels of 20 or 30 or 40, and we can do that all day long, every day. And even when we're not eating anything, the insulin levels can be high. But this is like taking a job. Carmen, you maybe you've taken a job at some point in your life where they told you were supposed to work 40 hours a week, but it really wasn't 40 hours a week. It was more of a salaried position, and they expect you to work like 80 hours a week.
70.
And you were working
72.
on the weekends and calling at night and all this kind of stuff. And so eventually, what do? You're not going to stick with that job forever.
You want me to tell you what I did? Because you're telling my story. I ended up having like an almost complete breakdown and having to leave, like literally turn in a notice and get out of there because my entire body was breaking down.
Yes.
You're
Well,
telling me, yeah, yeah,
that's exactly what happens with your pancreas. It
right.
eventually completely breaks down.
Mm-hmm.
And when it does break down, you can't produce the insulin anymore. And this is why you become a diabetic.
Yeah.
So that's why high levels of fasting insulin are the first thing that we see. And we see this because the cells are unhealthy. So this is the way that it works, if I can explain it in a sort of a nutshell. So when we eat a lot of carbs and processed sugars,
Mm-hmm.
what happens is we completely fill up our liver first. And this is what, this is why the metabolic reset diet that Dr. Christensen's putting out a book on is really interesting to me, is because we pack that liver full of glycogen, which is a storage form of glucose. Once that liver is completely unhealthy and packed full, those cells become resistant to insulin because they're so unhealthy. When our liver is completely full, what do you think is the next area of our body that we fill up? It's our muscle cells.
Yeah.
So our muscle cells become really resistant to the effects of insulin.
Mm.
And then finally, and by the way, our muscles store glucose as glycogen as well.
Mm-hmm.
Now, the third storage point for our excess carbs is where? It's our belly fat. And so this is why people, start to gain weight and their bellies get bigger and bigger and bigger, because our belly fat has an enormous capacity for hosting all these excess carbs. Now, we store them in our belly fat in a little bit different way. We store them as fatty acids. So fatty acids are as a principal storage form of energy there. So the idea in Dr. Christensen's metabolic reset, and I didn't see the whole thing. Did he talk about his metabolic reset?
We didn't go into that at all. We jumped all over and covered so many topics.
Okay, he's keeping that quiet, but he has a new book coming out at the beginning of next year that I had the honor of being able to read the first version of it. And the interesting thing about what he's talking about, he's saying we need to really heal the liver because it really starts in the liver. That's where we begin to develop the fasting or the insulin resistance. And that's really sort of what he was getting at by doing a metabolic reset.
Okay.
Insulin rises because the cells that are receptive to insulin become unhealthy. So we get insulin resistance in our adipocytes, our fat cells, we get insulin resistance in our muscle cells, and we get insulin resistance in our liver. And so some of these medications that people are put on are targeted to the insulin resistance in these various areas. And so that's why medicines fairly early on tend to be quite helpful.
Right.
But again, fasting insulin is the first sign that there's a problem. It's rarely checked. And I don't know what I was putting here, multiple. I'm not sure what that means. Fasting insulin less than 2 is considered to be ideal. So if somebody asks me, what are your biomarkers of longevity? The two things that come immediately to mind are very low levels of fasting insulin in somebody that has a normal blood sugar. And then also very high levels of sex hormone binding globulin, because this is...
That's interesting. Hold on. Go ahead and finish your sentence. I want to say something after that. Yeah, you're frozen. Let's give it a minute. It'll clear up. Let's give Dr. Allen a minute. If he drops off, you guys just stay put and he'll come back in. So don't go anywhere. So Dr. Allen, if you can hear me, if you want to log off and log back in, that usually brings people back on, and everybody else just kind of hang in there. We know he had a little bit of a sketchy signal at the very beginning, so give it a minute. This is fascinating stuff to me. I mean, hey, you guys aren't talking too much in the chat, but while we're waiting to see what happens with the signal, has anybody ever heard of that latent adult set diabetes before? Put in the chat if you had.
Okay.
You're back. Yeah, we're just kind of chatting. But you went off right where you said on the slide where you said that you like to see fasting insulin below 2, and then you said something about SHBG, which I was like, high levels of SHBG. That's where you were at, and I want to hear the end of that.
Oh, yeah. So sex hormone binding globulin is a protein that your liver makes. So in a person that has a really healthy liver and a really healthy metabolism, they tend to make lots of sex hormone binding globulin.
Okay.
Now, the only thing that will fool us, super high.
Yes.
Yeah, Amy Best is like super high, above normal.
Yes.
Most people who are, in metabolic, really good metabolic shape have really high levels. The only thing that fools us is if you're taking some hormones, because synthetic hormones will increase sex hormone binding globulin because you need to have those transport proteins made in excess.
Right.
So if you're not taking hormones and your sex hormone binding globulin level is really high, so like birth control pills will falsely elevate your sex hormone binding globulin. Then it becomes a biomarker that we can't really understand. But once you actually are off the hormones, we measure if it still remains high, it means you've got a great, your liver's working great.
Okay,
and a low fasting insulin is also the other one. So those are the two that I see as in the people that I have that are the healthiest. Those are two very consistent patterns that I see. So
I feel really good right now then, because my fasting insulin was like 1.0 and my SHBG was like 200 and something points above normal. And I panicked about it a little bit because I thought, well, SHBG binds to testosterone and makes it kind of useless in the body. And my testosterone was so low. So I was in that panic mode a couple of years ago about all of that. But I'm kind of happy to hear this now, right?
Oh yeah. Well, I mean, yeah, and again, you're falling into a very similar situation as a lot of the Navy SEALs. I mean, they're all in tremendous shape. They have really high levels of sex hormone binding globulin, and particularly in men, of course, that attachment with sex hormone binding globulin is very, very strong. So they have really a functional deficiency of their testosterone.
Right.
So if you measure bioavailable testosterone, which is free testosterone, making up 5% of the body's total, and testosterone bound to albumin, which makes up 45% of the total testosterone. That's a better measurement. So the bioavailable testosterone is a better measurement.
Right.
For women, lower bioavailable can be somewhat problematic, but particularly for men, because it's our primary hormone.
Right. Yeah. Are you going to go ahead and share your screen for us again?
Oh yeah, sure.
Yeah,
okay.
Yeah. Very.
We started getting off on that.
I'm not quite a Navy SEAL, but that makes me feel darn good.
Yeah, no, you're in. Yeah, it just means you're in fantastic shape, and the truth is, that's a much better pattern. Most of my patients who have a lot of metabolic disturbance end up having very low levels of sex hormone binding globulin, and this makes sense because their insulin levels are very high. All right, so I'm going to go back to this because I'm not sure you heard the end of this. So the progressive rise of fasting insulin is particularly problematic. And that's what we like to measure over time. I like to see people's fasting insulin levels going down, meaning that they're becoming much more sensitive to insulin. Insulin resistance can lead to hormone disruptions. In fact, we think it's the principal cause of PCOS, polycystic ovary syndrome. Polycystic ovary syndrome is less about ovaries having cysts on them and more about actually insulin resistance. So many people will put people on metformin, and it helps improve the insulin resistance.
Right.
And that ultimately will lead to normalization of the fasting insulin. But that's the reason why PCOS occurs. That's probably the most common reason, is because of insulin resistance.
Yeah.
All right, so definitions. Prediabetes. Okay, so what is prediabetes? Well, it's kind of funny. So we as doctors have decided it's arbitrary. Arbitrary in the fact that at some point in some time, somebody just said, okay, I'm drawing a line in the sand at 100, and I'm going to call that prediabetes. And at 126, I'm going to call that diabetes. The truth is, a lot of things can increase your fasting blood sugar. If you were in a car accident, for example, and you hadn't eaten anything all morning, but you're in a car accident, you come to the ER, I might check your blood sugar, going to be 150.
Right.
And you would say, am I diabetic? And I would say, no, you just had a super stressful event, and you had this super surge of cortisol, and you dumped a bunch of glucose into your blood thinking that you're going to need to fight off something. So when we measure just a fasting blood sugar alone, we like to make sure that a person is feeling great, they're not really under too much stress, they've slept well the night before, and we tend to do it. We tend to not diagnose you as a diabetic unless we've had two separate fasting blood sugars above 126.
Okay.
That's why they say two separate blood sugars 2 weeks apart. That's kind of why they've always said that about fasting glucose.
Right.
Now, A1C is a little bit different because A1C is a 3-month measurement, and it's much more stable. So the reality of it is, when we see you, we're looking at your A1C and your glucose together. So if your glucose is 126, but your A1C is 7, that's much more convincing that you actually have diabetes. So an
Okay.
A1C of 5.7 to 6.4 is considered to be prediabetes. A1Cs in prediabetes are fairly unreliable. I'll just tell you that.
Okay.
Because I've had people with A1Cs of 5.3, insulin levels super high, and I put them through a glucose tolerance test and they fail it. And when they fail the glucose tolerance test, they actually, I had somebody with an A1C of 5.3 actually have diabetes. So
Really?
I want to talk about the glucose tolerance test at the end of this because it
Okay.
is useful for some people.
Right.
And again, I talked about prediabetes raises the risk for type 2 diabetes, of course, and cardiovascular disease and cancers and so on. And 50% of your pancreas dies as you go through your pre-diabetic course. So as you go from an A1C to 5.7 to 6.4, about 50% of your pancreas tends to die. Now, you may say, okay, why is that? How did you know that? Well, they actually did studies where they did autopsies on people that were in car accidents that had just recently been diagnosed with type 2 diabetes, and they began to notice something really interesting, and they wrote papers on it. And that is, when you die and they do an autopsy on you, they cut out every organ of your body and they weigh it. They put it on a scale, and they actually weigh the actual mass of that organ. And it was very interesting to them because they noticed time and time again these patients who had just been diagnosed with type 2 diabetes, their pancreas weighed half as much as what a person that didn't have diabetes. So the idea was that they began to look for a pattern. They found it, that really about half as much of your organ is left by the time you're actually diagnosed with type 2 diabetes.
Wow.
So there really is destruction of the actual organ. And this is why your blood sugars one day may be 115, and then all of a sudden, once enough of those cells have died, it shoots up to 300, and voila, you get symptoms. We tend not to get symptoms from diabetes until our blood sugars are above 250. Well, why is that? It's because the kidney really can preserve the amount of water your system keeps in until you get to a level of 250 and becomes overwhelmed, and that glucose you start urinating out the excess glucose to the point where it grabs onto excess water. So it's much easier for a person to become dehydrated. And this is why you have the really thirsty all the time, because you're dry and your body's signaling you need to drink more water.
Yeah.
And then you're urinating all the time, is because the glucose is actually signaling your body to keep dumping. And so your kidneys are trying to keep up. They're dumping and dumping and dumping. And this is causing the symptoms that ultimately bring a patient to their doctor, and that is, I'm thirsty all the time, I'm urinating all the time, and I'm tired all the time. It's really because they're continuously trying to deal with that high level of sugar.
Yeah. So polyuria, polydipsia, it was something you would see on a diagnostic statement, medical statement, or whatever. If somebody was saying,
I mean, that would be something that your client would complain to you about, saying, I'm thirsty all the time and I'm urinating all the time, and that should signal you to say, gosh, have you ever been checked for diabetes? My point to you today is you should check everyone for prediabetes and even insulin resistance. And I'm encouraging people to get tested is really important, because the earlier we identify this problem, as you can see, time is beta cell. So if we can save them, save every beta cell counts. We need every single one.
Yeah.
So diabetes, so this is where the blood sugar is much higher than normal. Fasting blood sugar is 126 or more, and A1C is 6.5 or more. And this is what signals to us that there's a significant problem. And of course, if you become a diabetic, your risk for cancers and cardiovascular disease raises significantly. This slide is a mistake. It says raise the risk for type 2 diabetes. You actually have type 2 diabetes by that point.
Okay.
So now what really works here? Okay, so if we look at this is another slide. This is from the Diabetes Prevention Program. So this looked at 10 years of what works for these people. So at the bottom is the x-axis, so that's the years out from the study, the intervention. So it goes to 10 years. And then on the y-axis is the amount of incidence of diabetes. So these are how many people are ultimately diagnosed with diabetes that goes through this program. So as you can see, the purple line, which is lifestyle, has the best results of anything here. So they gave people a fake pill of metformin. It wasn't really metformin. It was just nothing. And they gave people metformin. And then they gave people just diet and exercise and no metformin. And you can see that lifestyle was clearly the winner. And I say that because even at 10 years out, the incidence of them having diabetes is at least, I would say, probably 7 to 10% lower than through metformin. Now, metformin was protective because if they didn't take metformin, they would have a much higher incidence. And so what we found in current research over the last decade is we found out that actually medications plus lifestyle intervention works even better than lifestyle intervention alone. So, but this study was to look at, can people just take, everybody wants a pill, right? And we're so focused on just give me a pill for that, doctor. I have a friend who's an ER doctor. He's kind of funny, but he went to his doctor, and his doctor was telling him how horrible his cholesterol was, and he had plaque and all this kind of stuff, and he needed to exercise and change the way he was eating and all that kind of stuff, and he was like, "Do you have anything else?" And the doctor was like, "Well, you should do this and that." And he was like, "Do you have anything else?" And finally, the doctor's like, "Well, I have a pill," and he was like, "I'll take that." And so that's the whole thing of our society is all around. I just want a pill to fix the problem. Yeah. The truth is, with this, it's an awesome place for a health coach to be with a niche in actually identifying people or taking in those people that have a high risk for developing diabetes. Because the earlier the intervention is, the stronger it is, the greater breadth that you have for an intervention, the better it is.
Yeah, isn't it funny that like this particular topic? Let me just talk about the parallels here. Not the parallels, but the the contradiction of everyone wants a pill, and then health coaches are like, you don't just take a pill. But in this case, it is actually protective and can be curative in some cases. So it's something that we need to open our minds to. That what, sometimes you got to have a pill. It's not always a natural. It's not always going to be berberine and chromium for high blood sugar. We have to think outside the box in a conventional way at times to do what's best for our clients, right? Oh, we're frozen. Are you there?
I feel like not enough people are talking about, what the research has actually shown. This is one of the very few instances where the research has shown that the more aggressive we are with medications up front, the better outcomes we're going to have. Now, you mentioned berberine. That is good. I mean, they've looked at the berberine as an equivalent to metformin. But again, metformin is still the absolute weakest thing you can give someone. Right. Now, having said that, I'm convinced there's many billionaires that are just taking metformin. They don't even have diabetes. They're just taking it because it's been shown, at least in rat studies, to prolong life. What metformin does is it really reduces the amount of calories that our body has to process. So it acts as something called a calorie restriction mimetic. So it mimics calorie restriction. And so a lot of people feel like, and in rats, we've shown that actually allows the rats to live longer. So people that truly want to live longer are convincing their providers to give them metformin even when they don't have any of this stuff. And I think what we may be missing is all those people walking around with high levels of fasting insulin that just haven't gone into prediabetes yet or diabetes. Right. Again, metformin can help with insulin resistance, and this is why people with PCOS are put on it. The idea here is there's other medications. In fact, I know it freaks people out, but I have some pre-diabetics on 3 different medicines. They never have to check their blood sugar at all because in combination, these 3 medicines will never lower their blood sugar too low. And that's what they do for a year. And then guess what? That bottom all this time, it completely healed their pancreas because we do repeat glucose tolerance tests. We've shown their pancreas has reverted back to normal. Wow. And then we just watch them every single year with another glucose tolerance test, and we see how they're able to handle the glucose over a period of 2 hours, because that's the gold standard for looking at how well your pancreas is really functioning. These other blood tests are great because they're more screening tests. The intervention really comes with glucose tolerance. And people aren't doing enough of those too, by the way.
Yeah, I had to do that when I was pregnant. I'll never forget. I sat there. I thought I was going to be sick. It was so bad.
Oh, you know what? I'm glad you brought up pregnancy. It turns out that if you develop a problem with sugar in pregnancy, so if you have gestational diabetes, your baby that you have has an 8-fold increased risk of diabetes. You have a 5 times increased risk because of gestational diabetes.
Right.
So it's interesting to me that and I talked to an endocrinologist from one of these higher level places about this because I felt it was so interesting. The way that your body's cells are programmed in utero to insulin, to be predisposed to insulin resistance, is enormous. So that baby itself has a higher risk than you do.
It's crazy.
For later on in life. And so not many people know that. And so if you're a woman out there who's listening, who has had gestational diabetes and had, children during that pregnancy, those children are even higher risk than you are. And you're at very high risk, by the way, if you have gestational diabetes, but your children are even higher risk. So it's important for them to know that and for them to monitor their blood sugars, their insulin levels, their glucose, and their A1Cs much earlier than other people might. And certainly getting a good lifestyle with good nutrition and good exercise programs, much more important for them earlier on than it may be for other people.
Right.
So what is the American Diabetes Association saying about all this? Well, okay, so they're saying that everyone who has prediabetes, that A1C between 5.7 to 6.4, needs to be in some type of ongoing support program. And the goal really for most people is to get a 7% weight loss and develop exercise. Now, why do you think exercise is so important for people? Do you have any idea why exercise is important? Like, what does exercise do that I told you was a principal problem in this whole sugar problem? If we're talking about storage tanks, any idea?
Yeah, it does. I mean, exercise lowers your blood sugar.
Yes, but it lowers your blood sugar because it increases the amount of myocytes that you have, and it reduces insulin resistance in the muscle cells. Because with more muscle cells and more muscle mass, you'll take in the insulin a lot better, thus lowering your insulin levels. And that actually helps with weight loss too. And so this is why, for me, people who have high levels of insulin tremendously benefit from building muscle. So I don't like them necessarily just thinking about, oh, I need to lose weight. I like to think about, okay, I want a weight loss, but I want to change my body composition.
Right.
Okay, I want less fat and I want more muscle, because muscle is protective for them.
Yeah.
And this is, again, one of the reasons why many weightlifters go on to develop diabetes, is because during the earlier portions of their life, they develop all these myocytes. And then when they stop competing and they stop paying as much attention to it, and their testosterone levels go lower, they stop taking the injectable testosterone or whatever they're doing, their muscle mass decreases to a point where all of a sudden they're much more susceptible to insulin resistance because they don't have all those muscle cells around. So there's a higher incidence of diabetes in people that are actually weightlifters, competitive type weightlifters, for that reason. So for the same reason, we want to increase muscle mass. Again, a health coaching program that focuses on a great exercise program that gets that person moving is good, but to get them to build muscle is even better because it lowers the insulin resistance in the muscle, therefore lowering the insulin resistance overall in the body. It will help trigger weight loss. Again, people need to be held accountable. This is from the ADA. They really felt like follow-up counseling is really important. And then, hey, metformin may be indicated here. And this is, again, the American Diabetes Association is so behind all the research. The guy that I worked with wrote over 700 peer-reviewed articles on prediabetes and diabetes. And, he's one of probably the greatest researchers in the world on diabetes and prediabetes. And he got an award from the American Diabetes Association. He gets up front to accept the award, and he spends an hour telling them what a horrible job they're doing as the American Diabetes Association, and how they're so far behind what the research is showing, and how they've allowed this problem to go out of control. Now we have a tsunami of diabetes, and it's all their fault. I think that's kind of a good place to be, right? You get the Lifetime Achievement Award, you get up there, to thank them, and you end up just totally telling everybody what a horrible job they're doing. So that's one. He's a 70-year-old guy, and he speaks his mind, and I love it because it's actually backed by demonstration of research. And these people, if they were paying attention and reading the studies, they would know that there's a lot more they could be doing that they're not. But from a health coaching perspective, this is an area where you could build a niche in this space, and you would be so busy. Because there are people out there that want help, and they want to know what to do, and their doctors are not giving them anything other than lose weight and exercise. I don't really know if it's necessary. That's what their position is right now. All right. So if you are using our LabWorks site here, you can go to the custom lab order page. And as you can see, the tabs to the left describe the tests, individual tests. And then to the right are the test descriptions. And so what I'm encouraging everybody to do is to screen people. So you would send them to this page. If you're an affiliate, you use your unique URL. And it looks like if you click on sugar metabolism there and diabetes screening, you'll see fasting insulin, glucose, and A1C. You can get all those checked for like $50. I think it's $59. So everyone should get that. I'm going to give you this coupon code to give out to your clients. It's called Webinar 20. It's $20 off. So we're really talking about, hey, you know, there's no better way to encourage them to get their glucose checked.
Right.
If they're just going to do I think our glucose alone is like $25 or A1C is $20. So literally for $5, they could get it checked if money was a deal. I would want them to get all checked, insulin, glucose, and A1C, because I think it's so important to do that. Everyone needs to be screened, and we try to make it as easy as possible. If you're a health coach and you're interested in building a program around what do I do with people with prediabetes, do you have any specifics you can give me? I actually do. I have quite a bit of information on that because I build a program from the ground up on prediabetes reversal. And so I've got a lot of materials about that, and it might be that maybe we could come back in a month or so and do that. And by then, maybe I could have a bunch of downloads for you that your people could download if they want to, and use actually in their clinical practice for prediabetes. The idea here is to just educate people and get the word out there. 90+% of people, 90% or more, have never been checked for prediabetes. Okay, so the idea here is screening people, bringing an awareness to the problem, and then encouraging them to discuss with a provider. Thinking about genetics is a huge risk factor for people.
Yeah.
All right. Do you want to talk about the glucose tolerance test, or is that a little too much for today?
It's probably too much for today. I would like to get to the questions first, and then if we have time at the end, let's do that. So I'll go ahead and just field them, just making sure that we haven't covered anything. But so Patricia, we've already answered that question. Laura's saying if part of the pancreas dies, can it regenerate? Or does it just not function 100% any longer? Good question.
Yeah, no, that's a great question. And the truth is we don't know the answer to that because we haven't done autopsies on people looking for regeneration of the pancreas. There are rat studies out there that show that the pancreas can regenerate under the right circumstances. But it's not like the liver. The liver has a very powerful regenerative process. I have a nephew who was almost killed in a car accident. He's 19 years old. He had a horrible liver laceration. He had an open pelvic fracture and leg fractures and facial fractures and rib fractures and all kinds of stuff. But his liver looked like it was about 50% plus destroyed.
Wow.
It wasn't but a few weeks, and his liver began to regenerate and began to function normally. So because he's young and he's healthy going into it, his body is able to recover the liver function much better. But even as we get older, there's some hope as long as we haven't had irreparable liver damage, like due to cirrhosis. The pancreas is a little bit trickier because it does not appear the pancreas has that same ability to regenerate. So we're more in line with trying to save cells while we can. And that's what the big push is around prediabetes, is we really want to identify these people and get the message out that, you know what, every second counts. Every piece of cake in your mouth counts. Your body, you need to eat a lot less sugar. And I'm sorry, but you're high risk because your genetics. And the longer you can do that, the better chance you'll have. Right.
Yeah. So, genetics, loads the gun, right? As Chris Kresser says, and then sugar pulls the trigger. I guess we could put a rhyme in there.
Yes.
Yeah. Okay. So Karen's saying that's interesting about the liver playing a part. Would someone who had hepatitis in the past have more difficulty controlling blood sugar? You guys are so smart.
All right, so so hepatitis in the past, so I'm assuming like a hepatitis A or something like that. Hepatitis B and C tend to be chronic unless you take an immune modulator, which can sometimes be curative for hepatitis B or C. But hepatitis, one of the most common causes of hepatitis is actually not really due to alcohol, and it's not really due to infection. It's actually due to belly fat being deposited within the liver itself, causing fatty liver disease. So people with fatty liver disease are much higher risk for developing insulin resistance and therefore diabetes. They're also a much higher risk of developing liver cancer. So if you have a person who has fatty liver, it's important for them to know that they need to lower their cancer risk and their risk for developing diabetes by simply doing some healthy weight loss. And again, it's not about, if you go and you do weight loss, this is the problem with weight loss, is that if you lose a ton of weight very quickly, most likely you lose way more muscle than you do fat. That's just the way the body works, and we starve it. And so a slow progressive weight loss is much more protective because we'll change our body composition in a much different way. We preserve muscle and we get rid of belly fat. Dr. Alan Christensen's book, The Metabolic Reset, I thought was very interesting because he goes through why you want to have your weight loss being very protective of muscle. So from my perspective as a diabetes expert, I'm looking at his book and I'm thinking, you know what, he's got something here, and he's not really talking about it, but it really helps for actually prediabetes and insulin resistance and protection from diabetes. So healthy, gradual weight loss is much more important than a sudden weight loss. And you'll notice these people who lose 30, 50 pounds within a month will almost always regain it back and then some. And of course, it slows down their thyroid and leads to a lot of other problems.
Right.
But yeah, no, I definitely think they're higher risk of both cancer as well as developing diabetes.
Yeah. Okay, so Andre, along the lines of liver, does the type of liver cleanse needed only happen under doctor's supervision as far as probably optimizing for health and trying to prevent diabetes and so on?
No, yeah. So, I mean, I don't think of it in terms of a liver cleanse as much as I think of it as a carb cleanse. I mean, the idea here is we're all eating too many sugars. If you look at the World Health Organization, and there's a great little documentary that was put out. I took my kids to it years ago. I don't know if you ever saw it. It's called Fed Up. It's the one by Katie Couric.
Yeah, amazing.
So I took my kids to see this movie. My 10-year-old, who was 6 at the time, said, "Dad, that was a worst movie I ever did see." But it was really talking about how the average American is consuming 150 to 200 grams of processed sugar per day outside of whole foods. So we're not talking about fruits or anything like that. We're talking about orange juice, for example. So if you begin to read labels and you only look for the word sugar, you're looking for that, how many grams of sugar is on this label. The average American's consuming 150 to 200. If you go to Dairy Queen and you get a Blizzard. Have you ever had one of those Blizzards? I have. Okay.
So long ago, but gosh, don't even, my mouth just watered.
That's right. I mean, your sex hormone binding globulin is so high that you must never do that. But I do that, and I do that every now and then. I'll be straight up honest with you. So every now and then I might go get a Blizzard. There's about 140 grams just in that Blizzard alone of what we're talking about. So just the idea here is that if you drink a Coke, that's 38 grams. If you go and you have milk, non-fat milk, that's 14 grams. The idea is that when you start looking for it, you're going to find it. And so I taught my kids, your daily limit is 25 grams a day. This is the World Health Organization. This is not Dr. Hopkins. I said, okay, it's 25 grams a day or less, and that's what you're going to do. And so my kids began to count sugar in every label that they had. And I said, you can eat as many whole foods as you want. You want to have 3 fruits a day? Fine with me. But I want you to actually look. And so addressing the elephant in the room is the number one thing that I encourage health coaches to do first. So if I'm telling you the statistics show that the average person's 150 to 200, I teach my client, number one, where are you at? I just want to know kind of where you're at. Is this a problem for you? Is it a problem for most people? Is it a problem for you? I don't believe in counting anything for very long. I don't believe in counting anything for very long because people don't do that, some might do it for a little bit, but I don't like that restrictive part of it. I like just saying, okay, I want an awareness. Do you have this problem or not? And let's try to get it closer to 25 grams a day or less. And that dramatically can actually lower glycogen stores in the liver and in the muscle and in the belly fat, and they'll lose weight. So I would say that's a great weight loss strategy for most people because that's the biggest problem.
Okay.
Alan Christensen's book, and I hate to keep talking about Alan Christensen here, but I'm plugging his book because I thought it was so good. His idea was you're decreasing this carb content, but you're taking high protein to preserve muscle. So you're still able to do your best at preserving muscle with much less calories. And what his book will tell you is that you're going to have a protein shake in the morning and then a protein shake in the afternoon. And then in the evening, you're going to have a little bit bigger meal, and it's going to be mainly just good solid vegetables. And by the way, throughout the day, you can snack on whole foods.
Right.
That's the whole concept, really. Saying it in a different way, which I think is a much easier way to follow for most people, because if you just tell them you can't eat this and you can't eat that, he gives you a 28-day plan in the book that you can kind of stick to. So I think it'll be a good resource for, for clients as they go out there for this problem, even though he wasn't really talking about this problem.
Right.
But this is a huge problem.
It is a huge problem. There's someone that I'm very close to that he's just a complete sugar junkie, like literally sugar, sugar, sugar across the board. And I'm that person that says, you live in that body. I don't live in it. I'm not going to tell you what to do, but I can, this webinar is going to be directly sent to this person because, when you care about someone, you want them to take better care of themselves. But everything that he eats keeps coming up in my head over and over again. And I'm like, oh my gosh, your poor liver, right? So I'm so appreciative of this webinar for many reasons, but that too, the people that I care about, the people that are in my life, I want them to be healthier and happier people,
Yes, it really is about, it's really about the liver, the muscle, and the belly fat, and it all works together. And insulin, unfortunately, then has other consequences in our body. Remember, it's a huge fat fertilizer. So if your client has, everything else looks normal, they tell you they're exercising and eating great, and you check a fasting insulin and their fasting insulin levels high, above normal in particular, that is the principal reason why they're struggling with their weight, because it's a fat fertilizer. It's telling them to store fat all the time. And by lowering their insulin, they will actually be able to lose weight, maybe for the first time in 20 or 30 or 40 years.
Yeah.
So
the hard part
is a biomarker of difficulty with weight loss. It's a hormone, and it's a hormone that keeps you from losing weight if it's high.
Yeah. And sadly, same with this person, he's very lean and is just a master, Spartan racer, has no performance issues with exercise. So it's almost like a free pass. In the mind, well, I do this and I do this. I'm in the top of my, division and all this. I'm like, well, but what is going on inside of you is the question. And I don't want it to take a heart attack. It's like sometimes it takes a heart attack for people to change their life. And so, I recommended the fasting insulin and HbA1c and all that. So we'll see what happens. So
yeah, it's just a simple screening test. For most people, the testing is not expensive. And now that we have direct access, he doesn't even have to go to his doctor to get it. You could literally say, hey, you should go get it done. It's $50. Here's a $20 off coupon, and there you go. And he really shouldn't complain that much. But I'm trying to make sure that everybody who wants to be screened can be screened super easy. They will literally get the blood work, and with their discount, all of this will be less than any copay they ever go to see their doctor. And if if you help them identify this as being an issue, you can dramatically help them. You can save them from blindness and from kidney failure. That's awesome. That's super awesome. And this is the role, I think, for health coaches, because you can literally design a program that will also hold them accountable, to what needs to be done. Because it's not easy. Telling people to eat less carbs is not easy.
No, it's not. So Stan is saying, if you're diagnosed with prediabetes, what are your key lifestyle interventions? I think we covered most of those: exercise, build muscle, don't eat processed foods, et cetera. Anything else you want to throw in there?
Yeah. So I think those are the main things. The other issue that you're going to want to look at is sleep too. So so if you've done my training program, of course, we recommend the Berlin and the Epworth sleep surveys. The reason why is because it picks up obstructive sleep apnea. Many people who have obstructive sleep apnea are undiagnosed. If they get it diagnosed and fixed, it will lower the insulin levels dramatically and actually reverse prediabetes. It's something that we don't think about, so therefore we don't check it. And as a health coach, if you're thinking about obstructive sleep apnea and you're directing them to the proper resources, then you can actually solve that problem without all the additional pain. Because again, obstructive sleep apnea causes you to surge insulin and cortisol all night long, storing belly fat and, killing off your pancreas. Yeah. So this is why it reverses prediabetes if it's fixed.
That's crazy. Yeah. Okay. So Diane is saying conflicting interaction between Hashimoto's thyroid and Armameds and metformin in a non-diabetic, because there's no question mark here, but is there anything you can speak to about that?
Okay, can you say that again? You're talking fast. I didn't catch that.
Yeah, she said conflicting interaction between Hashimoto's thyroid and Armameds and metformin in a non-diabetic. Are there any there she goes. Are there any studies on the confliction of that? Started the question out in the wrong way. Yeah. So anything you can say about the confliction on the metformin and Armour thyroid and things like that?
Yeah. So, well, I will tell you. So, Armor. I mean, I have many patients that are on metformin and Armor thyroid. Okay. So, I mean, Armor thyroid being T4 and T3 are good. Metformin by itself is good. Again, the number one thing with metformin is GI upset, and it occurs in at least 30% of people. But if you tell people that it's going to occur, you might have a little diarrhea, you might have a little bit of cramping, you might have a little bit of excess gas. But guess what? If you just can hang in there and keep taking it with food at a very low dose for at least 2 weeks, 95% of those people who have symptoms, the symptoms go away. Out of thousands and thousands of patients that I treated with prediabetes with metformin, I ended up only taking off probably 5 people off metformin ultimately. And that was because, they just couldn't, they had excess GI symptoms, probably from other reasons that the metformin just exacerbated and made it worse. But metformin is very safe, even interacting with Armor thyroid. I use it all the time. But if by the way, if your thyroid is not fixed properly, it's not treated properly, and your thyroid is too high or too low, that can cause prediabetes. It causes us to think that you actually have prediabetes, when in fact you don't at all. You just have an over or underactive thyroid that's leading to the sugar problem. So again, in a full workup in somebody who has prediabetes, looking at their thyroid and making sure that's optimized is one of the things that I do.
Yeah. Awesome. Everyone should have a full thyroid panel at some point past a specific age anyway, in my opinion.
Yes.
Okay.
Yeah.
Laura's saying we're going to do thyroid topic at some point, I'm sure. But Laura is saying glucose has slowly been rising. I'm not sure if this is you, Laura, or if it's a family member or what, but glucose now at 100, fasting insulin last year 8.9 is now at 10, A1C is now 5.2. Grandparent and aunt have diabetes, making lifestyle changes. So how often do you retest, and what other tests would be beneficial for prevention and proactive health?
Well, if I was being really proactive, I would actually go to our site and I would do a glucose tolerance test. A glucose tolerance test is a 2-hour test, and you drink the equivalent of 2 Sprites, and then they test your blood sugar and your insulin at 1 hour and then at 2 hours. It is the single best test to determine whether or not you truly are prediabetes, and it also can be quite predictive of whether or not you'll go on to develop type 2 diabetes. It's considered the gold standard. And when I first started the prediabetes and became the medical director and all that, I was really against doing the 2-hour glucose tolerance test because of everything you said. When you had to do it and you hated it and you didn't like the way it tasted and made some people makes them sick, especially if they're not used to the high sugars. So I kind of fought him a little bit on it. So can you imagine me fighting this guy who wrote 700 papers on it, just telling people don't want to do it, it's impractical. But I'm telling you, after me finally agreeing to it and just saying, you know what, Grandpa knows best, I started doing it and I started finding, oh my gosh, he is so right. So in somebody that has progressive rising insulin, progressive rising sugars, and their A1C is still lagging, because that's a lagging indicator, it'll be the last thing that goes up for most people. I put them through this test, and people tell me, oh, I can't drink this sugar and it's so high, it makes me feel weird. I'm like, look, this is the equivalent of taking half of a Blizzard through Dairy Queen. Okay, so if you've ever been to Dairy Queen, you've had a Blizzard, you can at least eat half of it. I mean, that's the sugar load. And it literally is like drinking 2 Sprites. So it's not going to kill you. Your blood sugar will go transiently high, but that's what we're testing. We want your sugar to be high because we're testing insulin. We want to test insulin. Now, again, most doctors will just measure sugar. They don't measure insulin because they're not really looking at the function of the pancreas.
Right.
So I would love to come on sometime and talk about the glucose tolerance test and how I interpret it, because I think it's really interesting, and I think once you see it, you'll be like, oh, wow, this makes a lot of sense. Not enough doctors are doing the test. It's a test he recommends, and there are patterns that you can see that will tell you you're in trouble or not. So we can tell, based on your glucose tolerance test, if you have a 1% chance of progression or an 80% chance. So the person that just asked the question, my question back to her would be, if you knew that your chance was 1% or 80% based on this one single test, is that test helpful to you? In other words, if you knew you had an 80% chance, would you be much more concerned and watchful and do all the things? And if it was 1%, would that be more reassuring? Because if the answer is yes, then that's the test you should do. And it's called a glucose tolerance test with insulin.
Let's throw this out there.
Lab order website.
Let's throw this out there. I'll go ahead and get one, and then I'll do the insulin resistance because I'm due for that now. I do it every 6 months. I just kind of keep my eye on it.
Let me make one thing clear. The way this is measured is we do a fasting glucose and a fasting insulin inside of that test. So there's no reason for you to order a fasting insulin as well or a glucose as well because it's included in that.
Oh,
so
cool.
We start with the baseline of doing an insulin, see if you have insulin resistance, and we do a glucose just to see what the baseline is. Then we give you the bottle to drink. It's usually an orange syrupy bottle. It doesn't taste great. And then after 1 hour, they draw a glucose and an insulin. And then after 2 hours, they draw another glucose and insulin. And from that, we're actually able to see kind of where you fall. It turns out that the 1 hour level seems to be the most predictive on whether or not you'll go on to develop type 2 diabetes.
Yeah, that one always makes me nervous. I mean, you always sit there just kind of, like, makes me nervous to wonder what's going to come back on that. Even though I've never had a problem, I didn't have it when I was pregnant or anything like that. It's one of those things you just sit and wonder about. But I'll throw this out there, for the first person that goes ahead and purchases the test and is allowing maybe Dr. Allen to look at it live, then I will pay for the test. So you got to PM me at carmenhunterhealth@gmail.com in the subject line. I want to do the lab glucose test. carmenhunterhealth@gmail.com right now. Tell me you want to do it. Show me that you purchased it. I will pay for it, but you have to allow him to talk about it live on our next talk about the glucose test. So let's throw that out.
Using your numbers, because that's when it's really most interesting. If you actually allow me to, we could even post your numbers on the Facebook page, right? So that people can see it, and then we will review it together, and we'll talk about the glucose tolerance test. It's a really cool test for people. That person that wrote in about their sugars going up and their insulin going up and wondering, what do I do? Do I need to be worried about this? It's actually the best test. It's the best thing for them to do to know what their eventual risk is.
Awesome.
It's a great test, and we don't do it enough. And I'm kind of glad because it's 2 hours, and everybody hates that. But most of my people, I tell them, look, you only have to do this once. If you pass it, that's great. If you fail it, it just means that we know and we can do something about it.
Right. Yeah. Better to have knowledge, you guys. Okay. We've got I got about 10 more minutes, and then I've got to get ready to get my kiddo. So let me roll through some of these questions.
Okay.
Christy is saying, this portion of the pancreas dies, can this be linked to pancreatic cancer?
Yeah. There's not definitive evidence that pancreatic cancer occurs because of diabetes or prediabetes.
Okay. Laura says, hell yes. So she's going to probably be the person that messages me first. She's the one that put that question in there. And I love the note here that she made. Make sure you call the draw site to make sure that they can do the glucose tolerance test, because not all draw sites will do it. Yeah. Good point. Okay. Stan says, I may have missed this if it was covered, but what are your thoughts on ketogenic eating lifestyle with intermittent fasting in 6 to a most 8 hour window to treat pre-diabetes or diabetes?
Okay. Say that again. I'm sorry.
I know I talk so fast. I may have missed this. That kind of speeds up as we get close to the end. But he's saying, what are your thoughts on a ketogenic eating lifestyle with intermittent fasting in a 6 at most to 8 hour window to help with this pre-diabetes or diabetes?
Yeah, no, I mean, I went to the American Diabetes Association convention and met all the top leaders in diabetes. And one of the big pushes was for using a ketogenic diet for treatment of diabetes, because it will totally reverse it. And I don't know that it reverses it. It just takes the burden off the pancreas because it's not having to process the carbs. Right. So in general, it is a treatment strategy. I've had patients on it up to 2 years. Every single person that has been on it has ultimately failed, meaning that they couldn't stick to the diet. It was too hard for them, and it usually involved a vacation and where they just got off track, for a month or two, and that's all it took, and then they were back into having high blood sugars again. But it is something that obviously it works if you don't eat any carbs at all, because you don't need insulin to process fat and protein. So it is a treatment strategy. There are a couple of people there at the convention that were really preaching it, but the reality of it is it's very restrictive for most people. I mean, if they're really going to do it correctly, it's very restrictive and it's very hard to stick to. It's a great way to lose weight, by the way, because most people have super high insulin levels, and when you get rid of that insulin, I mean, you start to really get weight. That's why people are really touting a keto approach to everything, because they're losing weight. But another approach that could be an alternative approach and probably much more adaptable to most people is the simple staying less than 25 grams of sugar a day instead of 150 to 200. And I'm telling you, just from experience of thousands and thousands of outcomes, it works for most people. So they don't have to be super restrictive. They just get back to eating whole foods again, paying attention to their sugar gram intake, and making better choices. They don't even count every day. My kids, they don't count. They just look and they just make a better choice. They go and they maybe pick out a cereal, and one has 10 grams, the other has sugar, and they choose the sick. I'm sorry, one has 10 grams, the other has 6 grams. They'll choose the 6 because they know that's healthier. And it does make a difference over time.
Yeah.
Now, somebody asked a question about how long does it take to go from a pre-diabetic to normal if you follow. Again, this is extremely individual. It all depends on your own situation. So it might be quick, or it might be not quick. It just sort of depends. And this is the value of testing to make sure that they get better. This is why my patients come and see me every 3 months to get repeat testing done, so we see if it's working. And by the way, it holds them accountable too. One of the best ways that you can hold somebody accountable for their nutrition on are they truly eating less carbs is measuring a fasting lipid panel and looking for their triglycerides. Their triglycerides will be real high. Remember, triglycerides are 3 fatty acids hooked together. And I told you that if your liver is completely full and your muscles completely full, you store excess carbs as fatty acids. 3 of them hooked together are transported as triglycerides. So triglycerides are a great way to see if somebody is sticking to the nutritional intervention that you want.
Mm-hmm. Interesting. That is interesting. Okay, we got time for about 3 more, I think, here. This question from Karen is interesting. I may have misunderstood, but I do remember a doctor saying we were born with a finite amount of insulin in our body from birth. Is this true?
Yeah. So the truth is that I don't know that we know that question necessarily. I've heard it described as our cells are being pre-programmed to die at a certain point, genetically. And this is why people who have both parents that have diabetes, they're very high risk, because at some point in their life, their cells just get tired and they poop out. So I don't know. I don't even know how you would test for that. But the idea is that genetics plays a huge role in the amount of risk that you're at. So again, my family, super strong diabetics all the way through the family. And, and it's something I'll always have to pay attention to and watch for.
Yeah. So you get tested how often? How often do you test?
Well, for me, I test annually for that problem. I haven't had any indication of it at this point. My fasting insulin level is super low, less than 2. And my blood sugars have been 85 or less. And so 85 or less is considered optimal. So far I look okay, but I'm probably more active than other members of my family. I have my brother. I monitor him more frequently because he's had the progressive increase in the sugars and his insulin level's higher, and he's struggling a little bit more with his weight. So my sister also had a little bit of prediabetes. So, our family is just high risk, and it depends on kind of where you're at, how closely you have to monitor somebody. And again, there's never a reason to check a blood test unless you're willing to do something about the result. So for them, even them, I tell them, okay, I want to test you, but if you're ready to, if you think you're ready to do a little intervention, let's do it. Otherwise, if they're happy with where they're at and they don't want to do it, I don't force it on them.
That's a good point. I like that. What you just say that again. Say that one more time, because I want health coaches to hear this, because this is a part that you play when it comes to health coaching people. You can make all the recommendations that you want, and you can get the black and white labs back. But if the client is resistant or married to their current lifestyle, what's the point? So say what you said again.
Yeah, I mean, blood tests are used to help people and hold them accountable, or to use them as a tool for compliance. And so if they're not willing to do anything, there's no reason for them to get a blood test. So I wouldn't ever recommend somebody wasting their time and money if they're not willing to do something about the result. Yeah. And so, Carmen, I know if you go and you do a 2-hour glucose tolerance test and you find that it's a surprise and something's really wrong, you're going to look for ways to optimize and change it. But if your friend, let's say that you're like all super happy, you want to intervene, you see him eating terrible, but if you yourself volunteer to pay for the test, but he's not really willing because he doesn't think there's a problem, even when shown the evidence, is not worth your time or money to pay for him. So I would discourage you to do that. Yeah. He needs to, on his own, say, you know what, I hear what you're saying. I trust you. I'll do this because I know that I'll do something about it. If it's right, I'll change the way I eat. But you know what, if I pass, I'm going to eat whatever I want to eat. And that's cool, because I mean, that kind of puts the issue to bed, at least for a while.
Yeah, exactly. Exactly. Okay. 2 more minutes, guys. Diane is saying from Facebook, Dawn is asking, I'm wondering how redox signaling molecules could play a part in this. I just joined forces with a company that found a way to stabilize these molecules in a bottle and have been seeing many lives changed already. Are you familiar with that?
I am not familiar with that.
Yeah, I think you
I'd
might
be
be
more.
talking about a product that starts with a P. I'm not sure, Dawn, if that's the case.
Yeah, she's welcome to email me and give me details, and I'll look into it
Mm,
and give her my opinion next time. I
okay,
wanted to get to one question here.
go
Maybe
ahead.
this is the last question, but this is something that, so somebody has told us that they were diagnosed unexpectedly with diabetes last week.
Mm-hmm.
Their fasting blood sugar was around 100. The doctor put her on metformin, 500 milligrams, two
400.
times per day.
Yeah, you said 100. Her fasting glucose was around 400. You said 100.
400, right.
Yeah.
Okay, 400, yes. And the doctor put her on metformin, 500 milligrams, 2 times per day. Knowing that I'm a health coach, he wants to give you a chance to do nutrition and lifestyle changes. After a week of meds and very restricted diet, I've gotten it down to 300. Should I give it more time or go back to the doctor? What should I be asking the doctor for right now? Okay, so here's what I would recommend for you. I want you to look up this guy. You can go to Google Scholar and look up this guy called Ralph DeFronzo. Okay, Ralph DeFronzo. And I want you to put in there Ralph DeFronzo pre-diabetes treatment. Or no, put in triple therapy for pre-diabetes.
Okay.
And just hopefully that alone will bring up a couple of his articles.
I think I pulled it up.
So here's the thing. This is my opinion. And so I'm not your doctor, but I'm going to tell you. My opinion is this is the old approach. Okay, this is why things aren't working. This is a big problem. Number one, you're not even on the dose of metformin that works the best. The dose of metformin that works the best is 2,000 milligrams per day. Now that's fine. Your doctor put you on this last week. Normally I start at 500 milligrams once a day with food, and then I'll do the next week I'll do 500 twice a day with food, and then the next week I'll do 2 500 milligram pills in the morning and 1 at night with food. And then the following week, we'll do 2 500s in the morning and 2 500s at night. So we do a slow progressive increase to 2,000 milligrams per day. We found out that 2,000 milligrams per day brings down your A1C and glucose more than 1,000 does, or more than 1,500 does. 2,000 is the sweet spot. If you go above 2,000, 2,500, you actually won't get the same benefit as 2,000. So you need to be on 2,000. That's what eventually you need to work yourself up to, in my opinion. Also, the other issue with that is your doctor puts you on twice a day. That tends to cause the GI side effects. That's why we start with 1 pill just 1 time a day for a week. Make sure you're tolerating that okay. And then you go to 2, you see, and then ultimately you go to 3 and 4. So the idea is slow progressive increase. The other problem here, your blood sugar is already super high. Half of your pancreas is already gone. You've lost 80% efficiency. You're functioning with around 20% efficiency. So you're in trouble. So in my opinion, you need to be on a GLP-1 analog. That's what they're called, GLP-1 analogs. You need to talk to your doctor about this. Very expensive medicine if not covered by insurance. And so not a lot of people get to benefit from them. But I love them if the insurance pays for them, because the side effect is that they actually generate weight loss. And so I've had people have tremendous amounts of weight loss on GLP-1 analogs. Side effect for that is nausea. And it's an injection. You have to do an injection once a week. Okay? But it's from that 1902 intervention. It literally is a synthetic hormone produced by your gut that tells the insulin that you have left to work better. So you need to be on a GLP-1 analog. The third medicine you should be on is called pioglitazone. Pioglitazone or Actos, ACTOS. And you take that just a small dose every day, like 15 milligrams a day. That's the triple therapy that's shown it works better than insulin, believe it or not, better than insulin. It generates weight loss, and it also will bring your blood sugar down under much better control. Because you're a health coach, yes, you should do nutrition and lifestyle changes, but this is the old way of thinking, okay? The old way of thinking is watch your weight and exercise, plus or minus metformin. If you do only this, I promise you, this is not going to work. Okay? Don't tell your doctor I said that. Don't tell him I said that. I'm just saying, like, ask him about triple therapy. Look into triple therapy for even pre-diabetes. And you can take him to studies. You can ask, you can see if it's covered by your insurance, but you need to look into a much more aggressive approach, because this is old way medicine and it doesn't work.
Awesome. That was.
And the longer that you try it, the more you'll decide it doesn't work. So that's what I would do. And again, don't tell them that old Dr. Allen told you that, because that'll get me in trouble. You get mad at me. But I'm just telling you, as a diabetes expert, that's the old way of thinking. So our goal here is to present you with the newest research. And by the way, again, these medicine, I mean, if anybody looks up Dr. DeFranzo and you take in a research paper by Dr. DeFranzo, you start reading about the stuff DeFranzo's putting out, your doctor will be like, oh my gosh, I should have known about this. And that's what we want. We want to up-level their IQ.
Yeah. Grab the link, you guys, before I end the meeting here. There's a link right there, scholargoogle.com citations. That leads to his studies. So grab it. And then we'll also throw it in the replay. So we're going to wrap up so I can go get my kid, even though I know there's lots of questions. Save your questions for next time. I've already gotten somebody asking about getting that test. So I'll do my test and we'll have them do their test. And we've got to, put them out there so we can understand this glucose tolerance test fully. And I'm okay with sharing my stuff. I'm pretty transparent anyway. But we'll have you back and we'll do that after we've gotten our labs back. We'll put that on the schedule, and maybe that'll be our next time that we talk, so we can kind of stay in line with what we're doing here and get everybody back to learn more.
Yeah, I think the best approach would be to do if we could get enough people to do the glucose tolerance test, that we can make the next one just going through every single person's results. Yeah. Because that's what helps people learn. If they just see one example, it's not as good as two. 2 is not as good as 5. So if we had enough to go through where over and over again people would see how we approach this, I think it'll be helpful. And again, if you're already a diabetic, like the person who has a blood sugar of 400 already on metformin, you do not need a glucose tolerance test. Okay, you already have diabetes. This is for people. This is for people that don't have diabetes already. It'll just your blood sugar go through the roof, and you'll feel terrible. Okay. Yeah. So don't do it if you have diabetes. Yeah.
So if anybody does this, like don't bombard my support. Don't bombard support, because we have to provide tickets from Zendesk and all. That's a little crazy. But if you do it, go ahead. If you do the lab and you're willing to share it, hang on to it. And then when we get the date set and we get this thing set up with a webinar link and everything, then I will go ahead and make arrangements to get those where we share the screen and we get the labs pulled up. But please don't start sending me your labs like that. Like that will be overwhelming. And we don't need that. We'll put this into some form that we can all do it in an efficient manner. So you and I will talk, and we'll get a date on the map. Anyone about the labs, I will talk to you guys, do a live in the Mentorship and Mastery group in Clarity. Thank you so much, Dr. Allen. You were just a wealth of information. This has been 2 days of like the 2 smartest Allens I've ever met in my entire life. And I just super appreciate you and can't wait to learn more. And I'm loving having you, bringing you to coaches every month. It's been really
well, thank you so much for having me on. And I'm definitely humbled. And Alan Christensen takes the cake, man. I'm not even gonna go there. That guy he's very impressive. Yeah, he's very impressive. I'm glad he's our friend.
Yeah, so. Me too. I'm just really happy to be able to talk to you guys and meet you again next year, of course, hopefully in person, maybe sometime before that we'll see each other. But all right, you guys, thank you so much. Dr. Allen, thank you, Amy. Hi, Amy. Goodbye, Amy. And bye. And I'll talk to you guys soon. Thanks so much.
Okay, bye-bye now.
Bye-bye.